Last week we had 2 guest speakers. This week we have 3 guest speakers. We might call them in-house guests because they're from this congregation. So I want to welcome all of you here and let you know that today is primarily to explore areas that you believe you need to know more about, and having to do with end-of-life issues. And I'm going to allow these guys to introduce themselves. And we'll start over here with Joel Yellen.
Yeah, good morning. I'm Joel Yelland. I'm a retired family physician, which is more or less a GP. I've spent almost all my career, my 30-plus year career, in rural situations, which means that during the day I was in clinic, and sometimes during the day and sometimes all night I was delivering babies or in the ICU or doing whatever needed to be done. They've asked me here to talk about some end-of-life issues. I've had a lot of experience doing it. Okay. Oh, okay. I guess I'm on. Yeah. So, I mean, death is a very difficult time. Yeah. It's we're all born, we live, and we die. It comes for everybody. And if you're not involved with it intimately yourself, often you need to do things, do end-of-life care for your loved ones. How many of you have had to deal with end-of-life issues, either with yourself or anybody else? That's almost everybody, okay? We're sort of at that stage of our lives where people have either dropped off.
Yeah, okay, now you're all right.
We're not getting the screening.
We're sort of getting closer to facing that ourselves.
Well,
raise your hand.
So
see that?
You've all had experience with it, but one thing that you probably don't have experience with is sort of getting inside a doctor's head, okay? During these times, these very difficult emotional times, and there's actually more than emotion wrapped up in it, people tend to look to their doctors to give them some guidance, okay? I call this navigation, okay? And this involves sometimes looking to the doctor to help you make decisions, okay? Because when it all comes down to it, almost always it's the patient's choice that determines the way medical care is going to go. That's the way it should be. Sometimes my job has been just to explain what other doctors have told you. Because as you know, they sort of speak a different language sometimes, okay? So it's both sort of a knowledge base that the doctor is, but also because, the doctor is sort of responsible, for carrying out the wishes of either the patient or the loved ones if the patient no longer has the ability to make those decisions for themselves, okay? So there's some things the doctor has to keep in mind too. First of all, legality, okay? Doctors are all licensed by the state. There are legal boundaries as far as what we can and cannot do, okay? And the doctor always has to keep that in mind, or they will very possibly lose their job and possibly lose their livelihood. I know one doctor in a town that I was living in. He was delivering a baby. That baby had known very, very serious birth defects and was not expected to live more than a few minutes. Okay, the doctor was lying there on the bassinet in agonal breathing, which means gasping breathing, and the doctor just put his hand over the baby's face. Okay, it was legally not, well, it wasn't legal. Okay. And not only that, but the parents obviously were very, very upset, and the guy faced a lot of problems. But it's not just the legal stuff. There are also professional responsibilities. Okay. What does a doctor do? Okay. One thing I found out very quickly in my career is the doctor's in charge in a lot of respects. Okay. When somebody, when you hear code blue on the overhead, you know, and the doctor walks in, somebody's got to take charge. That's the doc. Okay. However, they also have to keep in mind some of the legal stuff going on, which we'll get to later, meaning the advanced directives and living wills and so forth. Okay, that's a constraint. There are some ethical things involved. Okay, what would a reasonable human being do under any circumstances? Okay, and also compassionate. You know, I've sorry, I've sat around the bedside and cried with families. Okay, as their loved ones are passing on. Okay, doctors are human beings like everybody else. It's just a very special position during this time. So, so what does a doctor think? What are the discussions like with the patients and their families? Okay, in this end of life era. Okay, and actually there are two circumstances, at least two. One is when end of life is like expected. Okay, not imminent, but expected. Okay. First of all, I hope everybody in this room has an advance directive of some kind, you know, a living will or something else. The reason, or a durable power of attorney for healthcare in case the patient is not able to make decisions for themselves. Okay, it's really, really important. Okay, because the doctor basically is bound legally to go by whatever is on paper. Okay. So if you've got some idea as to how you want your death to go, okay, make it known. Okay, put it down on paper. Make sure the hospital's got a copy. Make sure your doctor's got a copy. Okay, because really we rely upon these heavily. So probably this will be described during the various meetings of this seminar. Okay, it's exactly what these things entail. Okay, so another situation might be hospice. Okay, when eventually the body just peters out to the point where more or less no more than 6 months of life are expected. Okay, then hospice is offered. Okay, you're not required to take it, but what this does is, first of all, it shifts everything over. Okay, when death is expected at some point, okay, they shift over to what's called compassionate care. Okay, or comfort care. Okay, that does not mean necessarily that you don't get any more medical treatment. Okay, although I've heard it argued by healthcare professionals that really some kind of acute problem is coming on, and they'll say, you know, what are you whining out? We're expecting you to die at some point. Okay, why do you want to be hospitalized at this point? Okay. Part of the problem is that these comfort measures, okay, are a gray area. Okay. For example, supplemental oxygen. Okay. You're keeping people alive, obviously, but really it's a comfort measure so they can breathe better. Okay. Anybody had the experience where they can't breathe? Pretty uncomfortable, isn't it? Yeah. So there are other ways that you can parse that, okay, to so it's not quite so black and white, okay. But generally speaking, hospice patients have 6 months or less to live, okay. Nobody knows when somebody's going to die unless it is like imminent. Okay. But people take their best guess. All right. So a doctor might say, well, um, there comes a point, you know, when we just when things are so run down in the body, where conditions are so serious that we just don't expect you to make it through this. Okay. Hopefully people will take that as it's meant, not as a piece of advice, basically, and not as a prediction that things are going to, you know, that you will die, dang it, and it's going to be no more than 6 months and you're going to die, and we're not going to do anything more for you. Okay. Hospice. Hospice is an at-home kind of a situation. The idea being to keep people out of the hospital if possible. Okay. I guess number one, it's a drain on the resources of healthcare in general, but also, you know, would you rather be sick at home or sick in a hospital? I'm really, in a way, hospitals suck, you know? I mean, they're there to keep you alive, but the trade-off is you're under their schedule. They can wake you up at night. In fact, they do. And it's sterile and sort of impersonal and somebody different every day by your bedside, and better at home. On the other hand, if you can't maintain, for example, comfort measures at home, then a hospital might be the only choice. All right. Hospice nurses generally make regular visits at least once a week. Okay. They're usually very, very experienced. Okay. By comfort measures, they're talking about generally pain control. Okay. Pain control is a difficult subject in this country these days because of the OxyContin thing. I'm a volunteer for a hospice organization. You know, I basically come in and not as a doctor, but as a friend, okay, to come in and talk to folks for a couple of hours a week. For example, the medicine of choice for pain relief is morphine. And everybody's got this idea, oh my God, morphine, okay? They're going to turn me into a junkie. No, it's an excellent pain medication and easily administered, okay? So don't get that idea. They also give medications for anxiety, medications to improve breathing. They do a quick physical exam to make sure everything's okay, talk to the patient, see how things are going, and do what they can. They've got contact with a doctor. I'm actually not sure whether people keep their own personal doctor when they go to hospice or not, but there is a hospice medical director who, you know, makes medical decisions for the nurses. Okay. When people go in the hospital, they're off of hospice, at least temporarily. After they get out of the hospital, they can be put back on again if they wish. Okay. But this is a legal thing. Now, one thing we should also talk about briefly is medical assistance in dying, okay, which, as I understand it, is not legal in the state. Yeah, it's legal in Washington State, where I came from, okay, so I'm familiar with it there. But this is a decision that you or your loved ones need to come to, okay? If they have what really is a terminal illness and really they're not doing well, they can decide to end life themselves, okay? If it's the passion of yours, I advise you to talk to the local folks and put some energy into it. Okay. And now, imminent death. Okay. When you're in the hospital or you're at home, I have done home visits to guide people through, the patients and their families, through this last few moments, okay? The first thing is something called status, code status, okay? Codes, as you know, code blue, code red, code yellow, et cetera. Code status is something that goes into the doctor's orders. I looked this up. It's been a while since I admitted somebody to the hospital, but There's a mnemonic which starts with admission, diagnosis, and has code status in there, okay? Code status is either full code, okay? Partial code, which varies with the hospital that you're in. And then either there's a no code, which means basically you let them pass, okay? Comfort measures as much as possible, but if they're imminently going to die, you just let them go, okay? And then there's sort of another gray area in there. There are do not resuscitate, DNR orders, okay? Which means basically no cardiopulmonary resuscitation. And the way I explain this is because, doctors look at this and the patients, the family look at this and they say, what the hell am I going to do? Okay. What's my decision going to be? A doctor can be very handy here. Okay. Or not, depending on the doctor. But do not resuscitate means basically no cardiac compressions. Okay. And no code, no crash cart medications and so forth. This requires, when people come in the hospital and they are at the point of death, okay, usually something's going on, okay? There is something in their body that is failing to the point where it just ain't gonna work anymore, okay? So do you pound on their chest? Okay, do you do cardiac compressions? Okay, on a frail rib cage, okay, possibly breaking bones, okay, for no point, okay? That's the question. And that's the decision that needs to be made. Do not intubate, a DNI, okay, means no tubes down the throat. That's a little bit more medically fuzzy, I guess, okay? But some people just don't like tubes down their throat, okay? And with other people, such as those with severe COPD, putting a tube down their throat means that they live with the tube for the rest of their lives, okay? It's not a done deal, but that's pretty much the way it goes. You got to make the decision. Tube feedings. Do you keep people alive artificially with putting a tube down their throat into their esophagus and stomach? Sometimes it's worth it, okay? People who don't have real serious medical problems can be kept alive that way until they recover, okay? But other people, it just makes no point. The last thing is, when do you terminate life support, okay? A lot of people are on life support when they're on the point of dying, okay? Frankly, I don't have a lot of experience with this because in a rural situation, okay, you can only go so far as keeping people alive, okay? And also people tend to have a better idea as to when things are really not going to work, okay? So you got to talk to the family because usually the patients are comatose by this point and decide when to pull the plug. And that leads me to one quick point. The advanced directives and the living will and so forth are not just for the patient and the doctor, for the families as well. You would be surprised at how many people show up at the bedside when somebody's dying who have not been in contact with these people for quite a while, but all of a sudden they want full court press at the end of life, okay? Why? I think it's guilt myself, okay? Haven't been in contact, haven't showed that they cared, and now here's their only chance. Sometimes it just doesn't make sense. Okay, I think we'll open this up for questions later on.
Thanks, Joel. No. I think we're going to use this microphone. Yeah. My name is Tom Sawyer. I think most of you know me. I have a PhD in medical psychology, practiced for about 25 years in large hospitals typically around stress-related medical disorders, but I was also the go-to guy for the terminally ill in the hospital where I was on staff in Phoenix. Also had the experience of being the medical psychologist to the AIDS unit at County in Maricopa County in Phoenix. So my interest is today is a little different than that. Joel did a fantastic job, I think, talking about the medical aspects of the dying process and how you relate to the doctor. I want to talk a little bit about the issues around being prepared. One of the things that I've seen quite a bit in my experience is that there's change happens in two ways. You either open the door and walk through, or you get thrown through the window. So what I'm going to talk about today is being prepared. And I want to talk mainly about Medicare. I want to talk mainly about a little bit more about advanced directives, and we'll then take questions later on. But I'd like to share a little bit. How many of you feel like you know Medicare rules and laws pretty well? Okay, all right. It might be good to give just a brief refresher. As you may know, Medicare is a social health insurance that was funded by the Johnson administration in 1965. And it's been around and morphed through the years into what we have today. And essentially, there are two types of Medicare coverage. There's what we call original Medicare, which is what was initially enacted. But in the early 2000s, the federal government, being concerned about the costs of Medicare, instituted what they call Medicare Advantage. So I want to spend just a minute talking about the differences there and help you kind of get your arms around all that. So original Medicare, there are three parts to it. There's Part A, which is in-hospital care, which is free. That's free to everybody that's qualified for Medicare. There's Part B, which is outpatient care, and that you pay for. You'll notice that you're paying $170 a month out of Social Security in most cases. Sometimes it's more than that. If you're a high income earner, you'll pay more, but that's for Part B. That's for outpatient coverage. Part D, and we'll come back to Part C in a minute, but Part D is your drug coverage. That's for covering your prescription medications. So those are the three parts to original Medicare. Now, there's a Part C that was launched again in the early 2000s called Medicare Advantage. And that was the government's attempt to get people to sign up for that plan because they can control the costs of that much better. The way that the services are paid for is on a per person basis rather than just any claim that's filed. So it's a little different payment scheme. So Medicare Advantage came in, and you'll hear it being promoted quite a bit. We're on the cusp of the sign-up period. You may know that the sign-up period for health plans for Medicare is October 15th through December 7th. So you're going to get flooded with promotional materials, sign up for our plan, or you're going to get tons of advertisement on television about it, because this is the period of time where you sign up for what you're going to get. Let me talk a little bit about the differences between the two plans. The main difference is that in original Medicare, you're free to go to whoever you want that takes Medicare. You don't have to get permission to go to whoever you want. That's what Medicare, original Medicare, allows you to do. Now, the cost of that is higher in this way. Most people that have original Medicare, we have coverage of the deductible of Part B. There's a deductible for in-hospital care, so about $1,600 if you go into the hospital. There's also many people have what's called a medical supplement or a Medicare supplement policy to help cover the deductibles and the co-insurance, which is about 20%. So the general plan for original Medicare is you have a deductible that you pay on Part B. You have a deductible to pay when you go into the hospital. You have a deductible of 20% or a co-insurance of 20% when you go to your doctor, unless you have a very good medical supplement or Medicare supplement policy. And there are 12 of them that have different levels of coverage. I think the attempt was to make it about as complicated as you can get. There are actually 15 different types of plans that you can select. 15. Now, I don't know about you, but I consider myself, having worked in healthcare and done benefit planning most of the last half of my life, I'm still confused. So if you're confused, join the club. But I'm going to try to demystify some of that if I can. So the advantage of Medicare Advantage is that there are 3 types of plans there. There's an HMO plan where you have a primary care doctor that has to refer you for any care that you get. Okay. There's a PPO plan, which is a network of doctors and hospitals that you can go to as long as you stay within the network. Then you get discounted services, or you can get what's called a fee-for-service plan, but they don't really exist. There are not many of them out there, so you can kind of ignore that one. So are you with me so far? So on Medicare Advantage, you elect that option, and there are several advantages and some disadvantages. The advantage is it's much lower cost. The initial premium is much lower cost. The average premium cost for Medicare Advantage plan is $12 a month. So they want you. And up to now, there's been incentives for insurance brokers to try to get people to sign up for Medicare Advantage. So you'll often be told that you're going to get groceries and hearing services and vision services and all that. And you may qualify for those, but not everybody does, because they are means tested. And you can get vision help and groceries and all that if you qualify financially, but they don't tell you that too much. So the advantage of Medicare Advantage is that it's very low cost up front, but you got to be careful on the back end. If you use a lot of medical services, you may get hit pretty hard with deductibles and co-insurance and so forth on the back end. Okay, I'm not here to try to sell you one way or the other. I'm just saying, number one, that it's complicated and everybody's situation is different. Okay. The advantage of original Medicare, like I said, is that you can go to anybody you want. And if you have a Medicare supplement policy, that will, depending upon which plan, there are 12 of those plans. The most common ones are F, G, and N. If you're familiar, I can talk about what the differences are there. F is not offered anymore if you are just signing up for Medicare now. It was way too generous. They cover everything. You have no costs at all under that plan. Under G, you have complete coverage for deductibles and co-insurance, except for the Part B deductible of $240 that you have to pay. Okay, so that's the only difference between F and G. And there is a difference there in that if the doctor bills more than Medicare pays, then you have to pay that. So that's N, right? So most people have one of those plans. There are others that have less benefit. I'm happy to talk more about that if you want, but I want you to understand that the main thing is that there are 2 general types of Medicare: Medicare Original, Medicare Advantage. The general rule of thumb is that if you go to a lot of specialists, I would encourage you to look at original Medicare. because in the long term, your costs are probably going to be lower. If you don't use a lot of medical services, then there's certainly some advantage in Medicare Advantage because the upfront costs are so low. And if you're not going to the doctor a lot, that may be an advantage. Or if you need additional services like vision or hearing or dentistry, things like that. Some of these plans include that. Okay, you with me so far? So you got Medicare Advantage and Original Medicare. Let me talk now just briefly about how Medicare addresses death and dying issues. Joel kind of touched on a couple things, but I think it's important to maybe hit some highlights there. First of all, Medicare Advantage plans, which are offered by health insurance companies, Aetna, Humana, United, whatever, along with Original Medicare. In Original Medicare, what happens is Medicare hires an administrator in each case, in each state, to pay the claims. All right. But in both cases, any hospice services is covered 100%. So you have full 100% coverage for hospice. Okay. Let me touch on a little bit about some of the advanced directives that Joel talked about. I think it's important to understand that we live in a state where you have to kind of jump through some hoops to die. It's kind of interesting. I think we go through more hoop jumping when we die than when we're born. But in the case of advanced directives, they have to be notarized in Arizona. So you must have notarized documents and you must have witnesses. Okay. And I would strongly encourage you, and I think Joel touched on this, when you have a medical power of attorney or a DNR, a do not resuscitate, or a living will, make multiple copies. Make multiple copies and hand them out to your family member, to your doctor, to your hospital, and then put a copy of your DNR on your refrigerator. If you're at home and you stop breathing and there's not a DNR, the EMTs are going to do whatever they can to keep you alive, even if it's against your wishes. You can't just tell them, oh, I don't want you to do that, or the family. You have to have something on your refrigerator that says clearly, do not resuscitate. So keep those things in mind as you plan your demise. Let me just touch on Medicaid and Medicare for a minute. Some of you may be on both. It's called dual eligibility. If you're low income and you're over 65, you're eligible for both. Those are called dual eligible plans. And they operate pretty much like I've described with the Original and Advantage plans. Okay? I think I'll stop at that point, and we'll take some questions later on if you have them. But I hope that clarifies at least a little bit the complexities of the decision process around planning for your care as you age.
And now the end is near, and so I face the final curtain. My friend, I'll make it clear, I'll state my case, of which I am certain. I've lived a life that's full, traveled each and every highway, and more, much more than this, I did it my way.
I guess you might call this a frosting on the cake. My name is Hobie Denny. I'm 97 years old, and I was raised in the hills of Kentucky, and I observed celebrations of life, which were funerals, long wakes, people tearing and screaming and hollering, and open caskets and all kinds of stuff. And then when I was a young adult, my mother passed away, and she had 3 sisters. And I was, as I say, a young adult. I was in charge of making the arrangements for her funeral. And the sisters came with me to the funeral home to help me. And we got into all kinds of complications because these women wanted to run the funeral their way, and they kept saying that's what Daisy would have wanted. Daisy would want to be dressed this way. Daisy would want her coffin liner to be this way. And they got into a cat fight. And it just blew me out. I thought it was horrible. Well, as I got older, we got into a situation where it became pretty normal to have what we call a celebration of life. And at this age, you can imagine I've attended a lot of them, some of them for parents, some for friends, some for worker associates, some for my own child. So what I'm trying to get across, we've talked a lot about the legal stuff that you should have done. And believe me, I'm a big advocate of planning ahead and getting that done. But think about this. A celebration of life is not for the dead person because they can't hear it. They're not going to know what's going on. But it can, if you plan it ahead, you can sort of entertain them and bring some joy to the occasion, because it is a passage. It's really interesting when you go to these celebrations of life, and especially when siblings start talking about the deceased person. And man, do you hear some stories that are really unique and weird and funny and heartwarming. And you just feel like you really know that person better than you had before. So I encourage you to do it now along with the legal things. Be sure you have it done. And on my particular program, the Celebration of Life, and incidentally, I've given a copy of it to Reverend Matthew, and I assume it will be in my file at the time it's needed. And I recommend that you select the music that you like. And obviously, I thought Frank Sinatra singing and I Did It My Way is a good introduction to it, because when you think about it, your life, you did it your way. So one of the things that was really important to me is the music. And I opened mine with Aaron Copland's Fanfare to Common Man. Now, this is one of the most big, raucous fanfares. It's huge. It's like for royalty, but it's for a common man. And it's impressive that it comes off that way. I really like that. I've also recommended that if you have poetry in mind, you include that in your program. In my particular case, I have included Desiderata. You may not know it, but check it out on the internet. I think it's one of the most meaningful writings about how to live your life in very concise, simple terms. So I guess what I'm saying is celebrate the life with joy. And I think you do it your way, and I think you do it now.
You want to take a break here?
So thank you all for introducing yourselves and telling us a little bit about what you do. Does everybody need to get up and wiggle just a minute? Anybody who does, do it. Come on, get up and wiggle. Whoa, boy, that feels good. Oh, yeah.
I call it rigid mortis. That's the phase you get before rigor mortis.
So now we are going to open this up to questions. I forgot to introduce myself even. I'm Betty Meikle. And we have with us today, I should introduce Mary Ganapol, who is the lead of I call it Death for Dignity, but you called it MAID, which is medicine in assistance of dying. Medical assistance in dying. There, I got it right finally. So Mary, would you stand, please? She will be with us in 2 weeks to talk with us about what's going on in Arizona. Okay. Thank you. So these guys are up here ready to answer any questions that you have.
I have a question.
And we have some questions, please, because we're recording this for Zoom and we are on Zoom at the same time. We want to make sure that we get all the questions, so I'll bring the mic around.
Tom, could you speak about the document 5 questions? The 5 questions, which I've given to my children.
Yeah, there's a document that's a wonderful planning tool called the 5 Wishes. I wish I had a copy to show you here, but maybe at some point, I know our speaker last week referred to that and was going to send a copy, I think, to Betty. So hopefully we can provide that at some point. But what it is it is essentially a critical planning tool. It covers everything from finances, spirituality, wishes of all kinds in terms of, your advanced directives, et cetera, et cetera. That's what it is. Yeah. Yes. Yeah. Let me just say again that all these advanced directives are legal documents, including the 5 Wishes. All these advanced directives are legal documents, and that's why they need to be notarized and witnessed.
Yeah, thank you for your presentations. They were really educational for me. I wanted to ask for your wishes for a celebration of life. I can't remember your name, but do you have like a schedule where maybe you review your wishes for what you might want at your celebration of life? And have you made any changes to your wishes for that, like for music or whatever?
Well, I've actually written my whole program for my celebration of life, and I've given copies of it to my son, who has durable power of attorney for my finance and health situation. I've given it to a dear friend who perhaps will be the moderator or hostess for the event. I've given a copy of it to Reverend Matthew, and I'm assume he's filed it someplace in my file here at UU. But yeah, you have to make sure that people know what you want, and the way to let them know is the people who will be most responsible
You want that to look
for
decent.
celebrating your life have that information. It saves them a lot of agony and concern, and I wonder what he would have wanted, or what she would have wanted. You got the music, you got the poetry. Oh, and the one thing I didn't mention, one of the bottom line things is having an open mic, so that people who come to the celebration can tell how they felt about you, including some really neat, dumb stories.
Hi, this is for Tom. Since my husband died, I really do need to get current power of attorneys, and I've been putting it off. Do I need to see a lawyer, or can I print something offline or online?
It's a good question. I think it would be wise to have an attorney at least review a document, simply because the laws are so specific that you want to make sure that any legal document you have is applicable to, if it's Arizona or wherever. Each state has their own requirements.
Okay.
So that's why you might want to have a local attorney at least review that. Yeah, yeah.
Okay, next question. How do I find, I mean, I've gone online looking for attorneys, but they all look like they do stuff that I don't necessarily need. What do I look for? Do I do like
An estate planner
okay.
who should be
And they
able
would be able
to do that. Yeah.
Okay.
I don't mean to pry here. Do you have an estate plan at this point?
I just have a will. Everything's going to my son.
Okay.
So I mean, all that's all
Yeah.
in order, but like you say, if something happens to me on the way home and I all of a sudden need help with whatever.
Yeah.
My husband won't help me out at this point, so I need to have it redone.
There are paralegals, I understand, that they can't give legal advice, but they can at least fill out forms too.
Okay.
So that's another option. But generally speaking, if it's not too much of a financial burden,
No, it wouldn't be.
I'd have an attorney, an estate planning attorney, look at whatever, that you're.
Okay,
you're doing.
thanks. Because yeah, I wouldn't want it to be a snafu at the
No,
last
no,
second and say it's
no.
not legal. Okay, thank you.
Sure.
I'm connected with a Bristol hospice company, and hospice doesn't mean you're going to be dying in 6 months anymore. You can have hospice care even though you have extended life. But one of the points I wanted to make, part of hospice care, they have a social worker who doesn't have any legal stuff, but they are very good about getting you the forms from the Attorney General and helping you do that. And of course, you have to do it legally and have it signed and notarized and stuff like that. But it's a no-cost way. If you happen to get into hospice, you can do it with a social worker.
Let me just add one thought there. There's actually, in qualifying for Medicare, there are exceptions where you don't have to be 65. So let me just touch on those while I'm thinking about it. One is if you have end-stage renal disease, you can get Medicare. Two, if you have Lou Gehrig's disease, you can get that. You don't have to wait until you're 65. So I just want to make that clear that there are a few exceptions. If you're disabled, you can get Medicare after you've been approved for SSI or Social Security disability for 2 years. Okay, so there are exceptions to the 65. Yeah.
If no one else has questions, I always have questions. This is probably maybe a medical kind of issue. I have been present and kind of managing the deaths of both of my parents and my mother-in-law, for all of them in hospice care at the end and in their home. And at that time, I was in the state of California, and the hospice workers, my parents were both right at the end, their end stages. We knew that there was nothing that we could do, that the course of death was happening. But at that time, we were given morphine. For my dad, we were given morphine, and we were given, is it Ativan? That's for the anxiety.
That's correct.
Okay.
Alprazolam.
Okay, so we were given both of those medications that we could manage my father's medication. He was dying. He had pancreatic cancer at the end. And
Wow.
yeah, it was hard. That was difficult. But I'm just wondering if in the state of I know that happened in the state of California, and frankly, that gave my mother and I to be able to have control over those medications at home, gave us some options. And I don't know if that's the case here in Arizona, if that's the same. If it has to be administered by a medical person, or if that's given, if the family or the legal representatives are given control of the medications.
Yeah, I've never practiced in the state of Arizona, but I'm sure that hospice depends heavily upon the families. And it goes the other way around too. So what hospice will provide is a supply of medications. Okay, they will come in, between 1 and 3 times a week, usually, depending. And but it's up to the family, to have.
Message to you.
If we're talking morphine.
Did you write it down in the chat?
To be able to fill the syringes and to set the alarms, okay, and put the medication on the tongue, well, buckle in the lip, and to basically manage things. Okay, you're on the spot. You know what the reaction is of the person you're taking care of. And therefore, actually, you're in a very good position to do the management. The problem is people are afraid of it. Okay, it's like, are we going to give too much? Are we going to give too little? This is a learning process. Okay, and eventually, you learn to be able to judge what's going on with your loved one. Okay, and give the appropriate treatment. Okay, and then the nurse checks up on you and refills your supply.
I mean, I'm not saying that, you say, you have a lot of control at that time with your loved one, but that for me, at the very end, for both my mother and my dad, I can't remember ever being as angry in my life as when they were totally comatose. And we knew there was no other option. They weren't going to leap up out of bed. And I remember just being so angry and I'm sorry if I'm misspeaking, but that I couldn't help them the same way that I can help my beloved animals with my vet. And I
don't think that
that's just my feeling about it.
There are some other schools of thought on this too, and that is that the death is a part of life, and it's something to be experienced. And yeah, don't mind me lapsing into to doctor talk here, but if somebody is I'm sort of losing my train of thought here. If you're if somebody is out of it, okay, to the point where they're unable to interact with anyone, and the reason for that is pain medications, you should consider if that's a good idea, okay, because there are a lot of people who think, my sister was a hospice nurse, okay, and so she would tell me not so much stories, but just her experiences, in general, and that it's a good idea for people to be like sort of awake and sort of aware of what's going on, so they can have the experience, okay? So their last experience in life can be as full as the rest of the experiences have been. On the other hand, pancreatic CA, for example, is notoriously painful, okay? And sometimes it's just best to keep them sedated. I'm sorry.
Thank you.
We had a cousin who was in his early 70s and healthy as a horse. And so he skipped getting Medicare Part D, which is the prescription plans. And then he got pancreatic cancer and couldn't afford the thousands and thousands of dollars of medication costs. So you didn't mention Medicare Part D. So can you talk a little bit about that?
Sure. Yeah, I think I did mention Part D is the prescription drug piece of original Medicare. Medicare Advantage drug coverage is usually covered under the umbrella of Medicare Advantage, but in original Medicare, you have to have a separate insurance program for prescription Part D. That's what it's called. Yeah. One thing that I noticed, and I defer to Joel here maybe, is that when I was working with people in the dying process, they would often have what are called PRN orders. And PRN means as needed. Some of you know that. Yeah, so it's a Latin term that means use them as needed. And so a lot of times toward the end of life, at least in the terminal stage, you'll see PRN orders, at least I did, quite often, where you can give the medication as often as needed. So I just want to make sure that people understand PRN. Yeah.
As far as drugs that are, your doctor says you should use this, let's just say I just recently had a diagnosis of you a little low in B12 vitamin, and there's other ones that, they want $70 a month for. I can't pull them up out of my memory, but it just seems that should one dispute what the pharmacy wants to charge you if you don't really understand the program in detail and you just know, oh, it's $75 today.
Yeah. Let me mention, there is a movement going on right now to lower the cost of prescription drugs. Some of you know that the U.S. has the highest cost in the world, at least 200% higher than any other country in the world. For example, I recently did a study for one of my son's classes on insulin, and you can buy insulin in Canada for $35, and here it's $400. Now the government has now instituted a cap at 35, but somebody's making up the difference of the 400. And I say that because you want to look at a couple options. If you're in a Medicare Advantage plan, when you buy that plan, you want to ask if your particular drug is covered in the formulary. You know what a formulary is? The medical director for the health plan determines which drugs that they're going to cover and which drugs they're not. And so if you're in a Medicare Advantage plan, you're buying into that, you want to ask, is my doctor on the panel? And are the drugs that I'm using covered? So those are very important things to make sure you've got a good fit there. I'll mention two different companies that have revolutionized the cost of drugs. One is called GoodRx. Some of you may be familiar with them. They do not cover every drug, but there's probably about 1,800 drugs that are in their formulary. And they basically, drug stores like CVS or Walgreens or whatever, they make their money from drugs. That's why they put the prescription counter at the back of the store to get you to come back there and pick up stuff while you're there. Anyway, but it's very important to understand that there are alternatives. GoodRx is one, and Care America is another one that have recently launched programs to cut the cost of drugs dramatically. Now, the cost of the drug that you're getting may actually be at full price lower than your deductible. So I mean, literally, you'd be amazed at the markup on drugs in this country. I was a pharmacy consultant for many years and fought with drug companies all the time about prescription drug costs. But you might look at those and see if your drug is on their formulary and look at maybe getting it that way. And you'd be amazed at how low cost these drugs are if they cover them. Yeah. So those are two options to the traditional, drug, CVS, whatever, Walgreens, whatever. Yeah.
Yeah, and there's another problem too. You guys are probably familiar with the term polypharmacy, okay? Whenever you walk into a doctor's office, you run the risk of getting another medication put on just because of the problem du jour, and it just gets added to the list. We are taught to go through the list of medications at least every once in a while to try to weed out the medications that are no longer needed, or maybe find a cheaper but equally effective alternative, right? In the service this week, we talked about problems and then opportunities that come from the problems. Yeah. Well, that's one of the things when you change doctors, for example. Okay. One of the things the new doctor is supposed to do is look through your list of medications and see what makes sense. Okay. And if nothing is making sense, then cut it out. Okay. There's no such thing as a drug without side effects. And there's no such thing as a free lunch either. So you can cut both costs and problems for the for the patients just by reviewing the list every once in a while. Yeah, I guess that's it.
I believe that we have some questions. We have several people with us online today and watching us on Zoom live. So I'm going to I'm going to ask Robin to let me know what those questions are, and we will pose them to you as well.
Wonder how many people are there.
Yeah, well, they're figuring that out. I just realized that that I never answered my own question. As far as termination of life support, okay. The person in question obviously cannot make the decision for themselves. So what do you think about when you think about withdrawing life support, pulling the plug, as they say, okay? And that is basically, is the patient going to make it or not, okay? Is it more of a burden on the patient to continue living, or is it a better idea just to let things go, okay? And in fancier hospitals, you can get EEGs and show no brain activity and all the rest of that stuff. If that is not available, you're going to take your best shot. And most doctors have enough experience with end of life. People who are, in almost every sense of the word, dead, okay, to make that decision as to whether to withdraw the ventilator or the IV or whatever and just let them go.
One other quick point too, and that is that if you want to change plans, let's say that you are in a original Medicare plan and you want to change to a Medicare Advantage plan, there's no problem with that. You just have to sign up during this window that I mentioned, October 15th to December 7th. However, if you want to change plans from a Medicare Advantage to a Medicare Original plan, you may need to go through medical underwriting. Now, what that means is that the company may not take you based on your medical history.
Get to the chat. You do that.
Okay, so be aware of that. In some states, there's no underwriting, but in Arizona there is, along with several other states. So if you want to go from a plan F to a plan G, and the cost is significant, for example, a plan F, an original Medicare, may be $200 or $300 a month more than a plan G. So there's big differences there. So you say, oh, well, I can pay the deductible and I'll save the $200 a month on the premium for the medical supplement plan, right? Well, the difficulty there is you may have to go through medical underwriting with the company to determine if you're healthy enough that they will take you. Okay? So be aware of that. There's medical underwriting when you change, anytime you change an original Medicare plan, you're going to go through medical underwriting in Arizona. Medicare Advantage, no. Okay.
So I'm here in the sound booth and the camera booth, I guess. And there are some questions from online. And the first one is it normal and legal for hospice to charge for room and board? I'm looking at a facility for hospice, not in-home care, that has a daily residential service fee of over $400. This seems like quite a lot.
Well, I don't know the circumstances there, but I would say in general that that's not legal. Anybody that's certified for hospice, their care is paid 100%. There should not be any out-of-pocket cost if you're actually certified for hospice care. That's my understanding.
Please repeat the question, Tom.
Well, that seems true. Yeah, I will plead ignorance there too. Yeah. Well, my understanding again is that, that hospice care that's needed is paid 100%. That's yeah. 5 days. Wow. Right. Interesting.
Okay, I have another question. It may have already been answered, but do any advance directives require a doctor's signature?
No. It's a legal document between the patient or the responsible party if the patient's not competent. It's a legal document expressing the wishes of the patient. Now, the doctor will receive a copy of it, but no, they don't need to sign it.
Yeah, the only role of the doctor here is advisory. Okay, because a lot of people don't know what to put down. Okay, so by talking to their doctor, they can get a better idea as to what's appropriate.
We have a question from someone on Zoom, Alan Desmond, who's asking a question about medical aid in dying. And Alan, I can say to you that in 2 weeks' time, we're going to have Mary Ganapol, who is the Southern Arizona lead for medical aid in dying, speak with us, and that may be the time for you to ask your question. Okay. Are there other questions from online?
I have one.
I'm sorry, I don't see more. If I'm wrong, we'll review this after the session is over, and I will get the questions to our panel today. I would like to say I appreciate them being here and answering questions so ably. Can we all give them a hand to say thank you? Wonderful. And next week, you will have the pleasure of finding out from a death doula exactly what it is that a death doula does. So until then, I ask you to join us in the Oasis room for some refreshments and talk to one another, talk to any of our speakers as you wish, and enjoy yourselves a little bit. Thank you so much for coming.